Good morning, good afternoon, and good evening from wherever you're joining from around the world. My name is Michael Craig. I'm Senior Advisor at the Centers for Disease Control and Prevention for Antimicrobial Resistance. And I'd like to welcome you all for the first ever CDC AMR Exchange. This is a new webinar series that CDC is launching to talk about issues related to antimicrobial resistance. And we consider this a conversation with CDC, a conversation with experts from around the world, and a conversation ultimately with you. And we see the exchange as an opportunity to highlight the latest research, latest opportunities that we have to address antimicrobial resistance, to talk about what's working and what's not, to share solutions that we're finding globally. And ultimately to have a collaboration with all of our One Health partners, with our audience who works and lives and fights day to day in healthcare, in the community, in the environment or the agricultural sector, in the fight against antimicrobial resistance. And so we welcome you. We're very humbled and we're very honored to have such tremendous interest in the topic and tremendous turnout for the topic today. We're also extremely honored to have a great group of speakers today. And we're going to jump into it right now. I'm going to start with Dr. Steve Morrison of CSIS. Steve is the Senior Vice President of Global Health Policy at the Center for Strategic and International Studies, which is a research nonprofit organization in Washington, D.C. that works with policymakers on global health policy topics and looks for bipartisan practical solutions to some of the world's most challenging international issues, including health issues like antimicrobial resistance. Steve, welcome.
Thank you. It's great to be with you.
So Steve, you have a tremendous experience, an extensive experience working with policymakers in the DC area, and we'd really appreciate to hear your perspective. We've been in the midst of a pandemic, of course, for 15 months or so. And, before that, 2018, 2019, there was a tremendous amount of momentum in the topic of antimicrobial resistance worldwide. And so I'm curious to hear your thoughts and your perspective on where DC policymakers are at with the pandemic and how has the pandemic changed or not changed their perspective on the world in which we live in.
Thanks very much. Congratulations on this new series, and a special thanks to you and your staff, Sarah Jones, Katie Capers, CJ Sterner, and putting this production together. And it's a real honor to be on the agenda here with Dawn, Ben, and Ramanan. It's a great team and a great opportunity. I want to first say something about CDC just for a minute. It's great to re-engage with CDC at this moment in time. I realize that CDC went through an exceedingly difficult period in 2020. The demands on its staff and the institution from COVID alone were extreme. But it was not simply the shock of COVID. In that period, CDC experienced unprecedented assaults from the White House, from outside the White House, from its allies, interference with its guidance, with its leadership, with its voice, its media appearances, the weekly morbidity and mortality reports. I mean, it's really heartening today to see CDC re-empowered and reinvigorated, to have such sterling leadership in the form of Rochelle Walensky and Ann Schuchat proceeding to restore science and to operate with such skill and bipartisanship and rebuilding America's confidence and trust in that institution, which is so important at home and abroad. And we know this is a tough period. We're in this period that's really a rather mixed period. We're in this sort of middle ground period. We had a session with Ann Schuchat earlier this week talking about vaccine confidence and misinformation in vis-a-vis vaccines in America. And she talked very eloquently about, look, we're in this, we've got a mixed population, some vaccinated, some not. all sorts of attitudinal issues that have to be addressed. And this is, I don't envy the complexity that CDC faces in this environment. And the same can be said for antimicrobial resistance. I mean, you're operating in a mixed environment that's highly fluid. So I don't admire the challenges. I don't envy you for the challenges, but I admire you for all the work that you do. So I have, in answer to your first question, I've got just a couple of points. One is, let's just remind ourselves about what AR represents. It is a part of the health security world. It is a part of the health security domain. The threat was increasingly recognized. It's a diffused, slow crisis. And yet you have, over the last 10 years in particular, made major advances in changing the understanding, the awareness, the grasp of the threat among policymakers and among the public that consumes health services and those in industry that are involved in creating solutions for this. There is high-level consciousness, I think, among our policymakers. In the executive branch, there's high-level consciousness among leadership within Congress, within media, and the like. And of course, obviously, it has a strong international framework, but putting in place the institutional, the CARB, the analyses, the data sets that have come forward, seeing things like the GAO report and others come forward, seeing very visible leadership at the highest levels within the US government matched up with people like Dame Sally Davies, all very heartening. The program did reasonably well during the Trump administration. Like many other global health programs and domestic health programs, its budgets were subject to proposed reductions, but able to circumnavigate that largely. One recent survey of policymakers, diverse group of policymakers, I found encouraging. There's an enduring strong awareness of this slow crisis, the need to prioritize it, and the need to shift a bit to put renewed focus on infection control in the healthcare settings, renewed focus on developing new technologies, and a renewed focus on detection and response. So that one poll that I was able to observe, it didn't say that this was a top line priority. What it said is there's consciousness, strong consciousness of the need to continue to work on this. This field has not suffered some gross erosion of knowledge and commitment among a diverse group of experts who are going to matter. It may not still be a pressing global priority and domestic priority, and there's still a funding gap, as we know, for the national plan of approximately $500 million, and that needs to be addressed. But we're still talking about 3 million infections a year and 35,000 deaths. That's significant. It has been, obviously, it has to take a backseat to consideration of 578,000 deaths from COVID-19. It has to obviously take a backseat in many respects in this COVID era. But let me get to my second point. My second point is antimicrobial resistance is not alone. Across the whole spectrum of important health areas, there has been disruption, there has been setbacks, there has been suspension, there has been diversion of staff, resources, diversion of leadership's attention. That the same argument can be said for HIV, TB, malaria, childhood immunizations, maternal and reproductive health. We've seen visits to hospitals interrupted and disrupted. And clinics, we've seen excess deaths rise. And this is in a way triggered a shared common struggle, which is to understand how much damage has been done in this period in these different sectors, how much staff and resources have been diverted, how to get back to the levels required, what steps have mitigated impacts and protected the gains. What is the future to look like in a world that is likely going to live with an endemic coronavirus pandemic, and in which health security is going to be a dominant lens in looking at the future. At home and abroad, this lens will be a very strong one, and we haven't reached the point yet in clarifying, okay, how do all of these other important component parts of our domestic and international health agenda fit within this new world? That is something that is a challenge that's on the table, for which we haven't yet answered most of those questions, but we're entering that moment right now. My third point is we are about to pivot at home. I think we should be optimistic about this pivot. I'll say a bit more about it in a second. But we also are not pivoting in terms of COVID outside of ourselves. The places that are pivoting are a small number at the moment of countries, and they tend to be the wealthy and most powerful. And we're still seeing runaway transmission, in India being the most dramatic, horrific, and heartbreaking instance. But it's this second and third wave phenomenon that we're seeing tear through low and middle income countries. We're not over that, and we may not be for some time. And we need to admit that reality and how frightening that is, and how much that will, I believe, dominate a lot of attention, particularly in these coming weeks as we enter a diplomatic season of G20, World Health Assembly, G7, and the like. But we are reaching a moment in America, I believe, in which we will reach a moment of confidence. The president has talked about 70% of adults vaccinated, fully vaccinated, as of July 4th. People not fully vaccinated, at least one dose, and a moment where we can begin to return to some normality, and that will accelerate. We hope that pockets of resistance and hesitation can be overcome, and that we can get those percentages up to something that begins to really repress the transmission. Right now, we're at about 40,000 cases a day. We need to get down to 10,000. That's going to require a major effort, but we are in that pivot moment where I believe it's going to be possible for policymakers and leaders at different levels to turn their attentions to the other important business that has had to take a back seat in this last period. And it's a debate, I believe, as we enter this moment of greater confidence and stability, in which we feel like we have moved beyond the cascading crises of a pandemic. We had 330,000 cases in January 8th and a daily weekly average of 250,000. Keep that in mind. And we're still heading towards roughly 600,000 deaths by August 1st, but we're slowing the extreme illness, the death, and the case counts pretty dramatically. And that is going to allow us to turn our attention to the plans for rebuilding our public health system at state, local levels, rebuilding our federal capacities. Antimicrobial resistance has to be at the table for that. It will be at the table for that. And I think you should be positioning yourself and thinking strategically about this moment of opportunity. And that includes R&D, the R&D agenda, which, the detection, surveillance, the basic capacities, the R&D agenda, all of those things have been elevated to a very high level by this crisis. And as we move to a calmer moment of more careful meditation around what we are to do as a country at home and abroad, I'm hopeful. Over to you, Michael.
Thank you, Steve. That was great. And I want to touch on something that you really alluded to there, and it's really the preparedness issues, and in particular in the U.S., and I don't think it's unique to the U.S., but it's certainly sure that we have seen for the past few decades, and that's this cycle of crisis and complacency that we fall in. And I think we've seen it with other public health issues, with HIV, with Ebola, with Zika, and now potentially with COVID. And how do we break that cycle? And how do we get ahead of it so that we can not be overwhelmed by things that are coming, and that we know they're coming, but we don't know when? And in particular, things like the challenges that we face globally with antimicrobial resistance.
Thank you, Michael. That is a most critical issue. in reading John Barry's famous book on the Spanish flu of 1918, 1919, the great influenza, one of the things that left me somewhat gobsmacked was the revelation that 670,000 people died at that time, and our population was a third the size it is today. When it was over, and of course it was wrapped into World War I, when it was over, people were desperate to forget and move on. According to John Barry, there's only a single memorial in the United States to the victims of that. And so, yes, you can look back and say there were some gains made in commitments, long-term commitments in science and public health that grew out of that. But I think that there was a very strong tendency towards this cycle of crisis followed by neglect and complacency. And that pattern has been documented time and time again. So what can be done? My advice would be a few things. One is move fast. Move fast while we are still in the midst of this. Do not believe that the planning and the execution of what comes next has to be postponed until we're at a fully calm moment, because I believe the pressures to move on and forget will intensify as we roll out of this year and into next year. So move fast. And to do what? First of all, to be very deliberate about the fact that the threat that you are focused upon persists and is still a live matter and requires renewed attention. I think that you have the framework, the policy framework, you have the institutional apparatus, you're advantaged by that. You have demonstrated gains, significant gains at dropping infection, in dropping fatality rates, at attempting to motivate industry to come forward. You need to celebrate and remind people of the gains, of the frameworks, of the progress that's been made in policy and in delivering results, and the need to move forward. I believe in terms of the COVID crisis that we face and the tendency that we may feel to the urge we may feel after this trauma, which is a colossal trauma for us and the rest of the world, unlike anything we've experienced really since World War II. There's a couple of other things that I think need to happen to avoid this, to break this cycle. One would be a 9/11 style commission, which would bring the best minds forward in a nonpartisan basis with great respect to begin to analyze what happened in this country, what happened abroad, but particularly focused upon our nation, and what needs to be strengthened looking ahead. And there are efforts underway. There's deliberations in Congress, there are deliberations outside of Congress around that. And I think that would be very important. Another very important thing is to memorialize those who have died and the families that have suffered the losses of those that they love. President Biden has done that twice in a dramatic and very moving way. And I think that changes the national dialogue. It shows respect, thoughtfulness about what this has meant. It reminds people. And when you come forward next with discussions around moving ahead and making sure that this does not happen again, it gives you a much stronger grounding in why we need to think and act in a way that does not forget, but builds on this. Data failures on the national level on COVID, data failures are at the center of the discussion. We are going to have a lot of discussion around improving data. We're going to have a lot of discussion around broken systems, particularly on the interface between federal, state, local levels, about underfinancing, understaffing our public health system and better integrating public health system with our medical providers, our hospitals and clinics. Those are all matters that you need to be at the table discussing. The last point I'd make in this regard, in terms of how do we break this cycle of crisis followed by complacency, is operate in concert with Congress on a bipartisan basis. There are people in Congress, you have strong champions in Congress. We are a very deeply divided country at a level of toxicity unlike anything we have really seen before. But on matters of health security, we still are able to muster bipartisan consensus and common action. And that gives me hope. Some aspects of our public health obviously have been highly politicized, and we've paid a price for that. This is not the case, to my mind, in antimicrobial resistance, and nor is it in many other areas. And we need to restore our sense of national purpose with that in mind. This affects all Americans, and you have already good champions within Congress. You should build on that, create more, and do it in Washington, but most importantly, do it in their constituencies, because that is where people are going to connect the dots and become more deeply invested in this issue. Thank you.
Thank you, Steve. And I just have quickly sort of a closing question to build on that and the bipartisanship, because that's obviously critically important, but also sometimes daunting. And you have a tremendous experience working on building bipartisanship related to HIV, and you have a history of working in that regard. What are your lessons learned for working on HIV and building bipartisanship for things like PEPFAR? And what are the lessons learned there for antimicrobial resistance as we move forward?
Well, that's a big question with a long answer. So I'll give you the very abbreviated answer, because I know your time is tight. The first week of June, we must note, the first week of June, just a few weeks from now, will be the 40th anniversary of the first reported case of HIV reported by CDC in its weekly morbidity and mortality report. And we will be reflecting a lot on what this means 40 years later, where we have 26 million people on antiretroviral therapy, but out of a total population of 38 million. So we have 12 million people out there we have not reached. We still have no cure. We still have no vaccine, but we've had major scientific advances of many types in terms of therapies and prevention methodologies. And those have been done in very strong partnerships with industry, between government and industry. We created a structure in the form of PEPFAR and a companion structure in the Global Fund that have endured almost 2 decades with sustained bipartisan support. And those two structures have been the most fundamental pillars for the global response on getting us to this point. But we've also had continued investments coming from NIH and elsewhere in the R&D sector, and in partnership with universities and other research institutes around the world. There continues to be concerns over setbacks about surveillance, enrollment, and prevention. There's great nervousness today about what has happened with COVID. There's a risk of regression. The populations served. We had a conversation recently with Monica Gandhi from UCSF, and the San Francisco General Hospital runs famous Ward 86, in which she said loneliness is a terrible problem among those who live with HIV, who are isolated and re-stigmatized, and she's seeing serious health problems. So looking back on these gains, what do we say? You need strong, authoritative, adaptive leadership at PEPFAR with the confidence and support of the President, Secretary of State, and others. You need to focus on proof of results. Data and accountability are fundamental to success. You need to take a long-term outlook when you look at how HIVs, multi-year funding, bipartisan support in Congress has been absolutely vital in fending off various threats to PEPFAR over the years. I can go into details if you wish. Having the Global Fund there as a companion has been very important in terms of burden sharing. The U.S. making an investment in 1/3 of the funding needs of the Global Fund has brought others on board. That's been terribly important. And then lastly, obviously, having a coalition of external partners those living with the disease, those who are advocates, those who are coming from the philanthropic world, the provider world, industry, and the like, the faith community. They've stayed with HIV over a 20-year period through thick and thin, and they remain elementary to the successes. So I think some of those lessons, I hope, are immediately evident how vital they could be in building and sustaining the movement that you are leading.
Absolutely. Thank you, Steve. And thank you for your insights, and thanks for joining us later on for the group Q&A. And we're going to turn to our next speaker. And I do want to just reflect that, I think Steve gave us sort of a recipe for success with policymakers and opportunities for us to the resistance agenda and to consider how we best do that. And our next speaker is one who, if you've worked in the field of antimicrobial resistance, you know all too well. He is a consummate speaker, and his organization is always putting out incredibly insightful and interesting updates to research, and he has been a consummate advocate globally for the topic. So I'd like to introduce Ramanan Laxminarayan. Ramanan is the Executive Director for the Center for Disease Dynamics, Economics, and Policy. Ramanan, welcome. And I think right now you're joining us from India, where you're not working on antimicrobial resistance currently, but you are in the midst and working tirelessly on the COVID crisis. And so I wonder if you could just start by, telling us what's going on there, what you've been working on, what's the situation, and share your perspective there.
Thanks, Michael, and thanks to CDC for organizing this. It's a great series, and I look forward to seeing more of these. So I don't have to explain the situation in India. It's beyond tragic. It's constant. I mean, just in the last 10 minutes, I just found out about the 40-year-old husband of our program officer and one of the foundations we work with. Her husband died, leaving her and her 4-year-old child. It happens all the time. I lost my finance head 3 days ago. It's a very personal tragedy. I know many people in the US have faced this, but I don't think we quite saw the age group of so many young people die of COVID, as we're seeing in India. And it's partly a function of just the age structure of the population, which is that there's a lot of young people. 65% of the population is under the age of 35, but possibly effects of new variants that we don't really fully understand. And of course, fueled entirely by, what I would call it's a self-goal, it's a self-inflicted wound to some extent, where the virus didn't do damage. I think poor governance and poor health systems have done significant damage. And many people are dying for reasons that they just shouldn't be dying. They're dying because of lack of medical oxygen. And when you run out of medical oxygen, even for a day or two, when you critically need it, the damage done to the lungs and to the patient is so severe, they never really recover from it. So the last 2 weeks, about 2 weeks ago, because of this colleague of mine, not having enough oxygen and us being, it was difficult to source oxygen. We had to send for cylinders from, 5 hours away and 6 hours away, people standing in line for 24 hours, that we launched at CDEP Oxygen for India, oxygenforindia.org. And, we raised about $10 million in just about 10 days, actually largely from the US and from around the world, including in India, to be able to solve this last mile delivery problem of oxygen to people. And it's not as if there is no medical oxygen in India. It's just that it happens to be in places that are different from the places where the patients really need them. And a good health infrastructure would have built that connectivity with cylinders and systems. And I think that the opportunity to have prepared for this wave just didn't happen. And it's sort of, I think there are a few tragedies here, Michael. One is the first tragedy is that it's just a poor understanding of science, whether by the policymakers or the public. I often get asked this question. I got asked this question right from the first wave, which is how big will the wave be? How long will the wave last? And you try to explain it's actually not something which is exogenous. It's not like an asteroid hit on the Earth where the asteroid is proceeding at a certain rate. the rate at which we suffer is entirely dependent on us. It depends on how much we open up. It depends on how we behave, whether we mask. The virus has its dynamics, but our control on those dynamics is actually quite significant. So back in January and February, I think we didn't misread the virus, but we misread the policy response. And I had thought that having suffered through 1 year of COVID, that the system would be better prepared, and that system would be better prepared both in terms of healthcare resources as well as in terms of having the initiative to keep the masking and all of that going on. That was not to be the case. And people saw COVID going away, and the policymakers opened up everything from mass bathing events to election rallies to everything else. And the communication message that was sent by this opening up was to everyone: just don't worry about it. It's over. COVID is finished. And I think that people are surprised by the ferocity of the virus. It's not the ferocity of the virus. It's just the ferocity of the dynamics of transmission, which at the end of the day is driven by complacency, right? So, and this is, I think, a cautionary tale, not just for other developing countries. I feel it's a cautionary tale even for the US. I worry that this could still come back. We're not out of the woods yet in the States. And with large populations that have still not been fully vaccinated, I think it's important to make sure that those restrictions stay in place till the end of the year. And to have another wave in the US is just, it's unnecessary. And if it happens, it's unforgivable. Because what's happening now is really what could happen really anywhere else. And I think at the start of this, the foreign minister of Singapore had said that this would be a test of three things: of governance, of health systems, and of social cohesiveness, whether societies are willing to trust and work with each other. Now, we know that in the States, the health system existed, but we didn't have the governance. And the social cohesiveness was not always there. There's some people who believed in masking and some people who didn't. In India, it was the opposite. The early stages, there was governance. There was a willingness to act when there were 500 cases and 10 deaths, which was driven by epidemiological projections, which I think was remarkable that a country would shut down that way. And it helped. The health system was not working, and the social cohesiveness is not really, it's not really present. And now all three have collapsed. The governance has also collapsed, and the other two also are not there in place. Now, fortunately, I think we've recovered a sense of governance in the States, which would help along with the health system, that we really don't have to have that same sort of problem there. But I think for India, it's going to be a long, tough road ahead. Not just to get to the end of this wave, but also what happens after this. There was no planning for vaccination. India exported vaccines, which I don't think was a bad thing, but India didn't plan for its own vaccine supply. There was no Operation Warp Speed kind of, investment in production capacity here. So it will take a long time for all of India to get vaccinated. And the impact on other developing countries, particularly Africa, is going to be significant. I really worry about that. I worry about the new strains because the variants, I think there's a very good op-ed in today's New York Times by my friend Shahid Jamil, who talks about what we know from animal models on the B1617 and the different lineages, from that. We don't have good scientific data. As I said, one of the tragic things in this is that this disease has been managed as a PR exercise rather than really managed as a disease. And that's really been the problem. And maybe that's just the way in which, epidemics happen. They transcend from being health issues to being, public relations issues. And our experience of HIV shows that that's precisely the wrong way to do it, because the experience of HIV was countries like Uganda and Thailand that confronted the virus, were open about it, didn't fudge numbers, talked about the cases, then provided the numbers to allow people to self-protect, which at the end of the day is the most powerful force that shapes the trajectory of transmission. And countries that did not do that, whether they were Botswana or Malawi or South Africa, suffered a lot with HIV because they were not upfront, and then they tried to manage the PR rather than managing the virus. And I think we had a period of managing the PR rather than managing the virus in the States, and fortunately we're out of that phase. But in India, I think we're still in that PR phase, and that's the reason why I think that it's going to take a long time for India to really emerge from where things are. And last, I'll say, all collectively, I think these variants are of concern, but I really do worry about Africa as well. Africa is not protected by vaccination, has weaker health systems than even India, and the governance capabilities are not great. And the only thing that has been common to the whole world is a sense of exceptionalism, right? So the exceptionalism is that when it happened in China, we all thought, oh, it's going to happen in China, it's not here. That's what the Italians thought till it hit them. And then the Brits looked at the Italians and the Iranians and said, oh, that's happening in those places. That's not really about us. I mean, not on a significant scale. I'm sure we've made that mistake around the world. India certainly made that mistake. The US has made that mistake. And I think the only truth in this entire thing is that there is no exceptionalism. We're all equally susceptible to this virus. And the only way out is through vaccination. And, I just wish that we approached it in that way, that we had truly a war footing to vaccinate the whole world within the next 6 months, because that's really what's needed at this point. Thank you.
Thank you, Ramadan, for sharing that. And I think we can maybe in the chat get something about the organization, the Oxygen to India, so we can share that and people can get aware and see opportunities to help support what's going on there. And, I think that, bottom line, we're having unnecessary tragedy. And I thank you for so eloquently, describing the circumstances of why that's happening and the scope and the breadth of it. And so I want to, you are one of the world's leading experts on antimicrobial resistance as well. And so would welcome your thoughts. And you guys, CDEP put out a tremendous paper this year that I thought was, I recommend to everybody who's watching this, and I always share it with folks. But you put out this paper, a report that was really an inventory of every country of the world and what they're doing on antimicrobial resistance or what they're not doing on antimicrobial resistance. And so I want you to sort of maybe share your perspective on that. What you found most illuminating, what you found most aggravating, what are the biggest insights of it? And then I guess the other thing, if you can sort of share, how do you think what you put out is already changing because of the pandemic, and what is sort of the long-lasting impact of the pandemic on antimicrobial resistance and countries of the world? You sort of touched on some of the areas of the world like Africa that are already incredibly vulnerable for the pandemic, but they're also, a lot of these areas are already vulnerable and challenged by antimicrobial resistance. So how, when we start to overlay those maps and those issues, what do you see happening, and what are the conclusions that you're drawing?
Right. Thanks, Michael. So the report that Michael's referring to is called The State of the World's Antibiotics. We put one out, first in 2015, and then we put one out at the beginning of this year. It was actually, it's been a 2 or 3 year exercise to get it all ready. And as he mentioned, the main idea behind the report was first to really, it's an update on what's going on with AMR, but also to be able to put out a set of dashboards that capture the multiple sectors and indicators that would indicate whether we're making progress on AMR at all in different countries. And AMR, we know, is a multi-sectoral problem, and it's something which has to be tracked in a way that's very different from, just say, malaria, for instance, where it's, you can look at the plasmodium prevalence rates, or you can look at numbers of cases or whatever. Here, it's a lot more complicated because there are many factors that drive drug resistance, and we also want to be mindful of the fact that lack of access to antibiotics still kills a lot of people. And while we're worried about resistance, we don't want to necessarily restrict access to antibiotics when it's actually appropriate. So I think that in the process of putting that report together, what struck me particularly was that this One Health way, and we talk about One Health all the time, but it's really time for us to truly embrace One Health as really our framing on public health. And I think if COVID has not taught us that, then nothing really will. In fact, I'm not even sure we should look at AMR alone. I think we need to look at everything in this One Health manner, particularly when there's the zoonotic and, zoonotic connect, and look comprehensively at what we're doing at the animal, environment, and human sectors, and see how some countries do very well, on the human side, but are not doing as much on the animal side or vice versa. And also in terms of public health infrastructure, on governance, all of which make a difference for AMR. Now, one of the interesting things that we found in a study that we published in Lancet Planetary Health about 2 years ago was that, it's pretty much received wisdom based on a well-known paper by Herman Goossens and colleagues in 2005, that the link between antimicrobial consumption and resistance is pretty robust in Europe. We've had a number of studies in the US that show that same link, that it's pretty robust. But when we looked around the world, that link is not so robust at all. In other words, selection pressure because of antibiotic consumption is only one factor and not even the most important factor. It's the transmission of resistant pathogens, whether through poor infection control or through poor water and sanitation, hand hygiene, that these are really the ways in which resistance gets around. So you don't need to select for resistance everywhere. There's just the transmission of resistant pathogens that's really important. And I think that was an eye-opener, because it just means that focusing just on reducing consumption is not going to be our way out of the AMR crisis. We're going to have to do a lot more than that. And certainly, while that is important, it's just one piece. So I would do that. I would think that that is the main takeaway from the report, which is that we need to make progress on a number of things. And if we think that's daunting, then we're going to suffer the consequences. But I think it's worthwhile to really pick up each of those pieces, whether it's vaccination rates, rates of rotavirus or pneumococcal vaccination. One of the things we drew upon for that report, Michael, was a series of studies that we published, starting with a paper that came out in Nature in April of last year. So obviously it wasn't read very much because it was the middle of COVID. But this paper was looking at pneumococcal and rotavirus vaccination and the impact on antibiotic consumption. And it's a very, very direct effect. And we have another paper that will come out soon on RSV vaccination in the context of clinical trials and the effect on antibiotic consumption. So I think that vaccination, infection control, water and sanitation, these should be three large pillars for how we approach things, particularly in countries outside the high-income world. So that's one. I think your second question was really related to, in the context of COVID, how things have really changed, whether it's been deprioritized or where it goes. I think the positive, if there's anything at all out of this, is that perhaps COVID makes us take One Health a little more seriously. So to that extent, I think our AMR agenda is helpful. I think the other part is also that there is an ongoing crisis with COVID itself. I know 3 people in hospital right now who have acute respiratory distress syndrome, ARDS, and they have secondary bacterial pathogens. And, they're both at risk for a cardiac event, but they're also at risk for, they do have a severe bacterial infection. And, managing these in hospitals is really a challenge. And this is not uncommon at all. It's happening all over the place. Many people are dying of COVID, quote unquote, but they're actually dying of a secondary bacterial infection, which again was something which happened during the 1918 flu and which we've written papers about. But, when it happens in real time, no one's looking at papers. They just are, dealing with it as it is. So I think we also need to measure the impact of AMR on mortality from COVID in a much more careful way. And that's good. That's a science agenda that lies ahead of us, so that while we're preparing for the next viral pandemic, we're also mindful of the effect of secondary bacterial pathogens. And then the third part is really in terms of global health governance, in terms of how we manage, infectious diseases more generally. AMR is a much more slow-moving issue to some extent than these viral pandemics that spread very quickly. But that is not to say that it couldn't spread quickly with AMR as well, right? It is possible. It's theoretically possible that it could happen. We just don't have a direct experience with it. So hopefully we put together the global infrastructure that is not dependent on a quote unquote, just a democracy-based entity like WHO, which has significant challenges in taking on their member states, particularly the larger member states, in challenging them on what they're doing. But we truly have a global health apparatus that protects all of us, regardless of which country we happen to be in or anywhere else. And I just wish that we could solve that. And if we could solve that, then we would be prepared for this and for other issues like climate change. But if we don't solve this, and this is our last wake-up call, I think we're really in for big trouble. So I think we should take this opportunity to really move this AMR agenda up to that level of solving for it in the context of global health security. And I think CDC is doing a great job on this, but you guys need a lot more resources and a lot more power to really power that as a global agenda, working with other U.S. agencies and, of course, with other countries around the world. Thank you.
Ramanan, I want to thank you. I want to thank you personally for all of your work, of course, over the years on antimicrobial resistance and your leadership there. But I also want to thank you for your tireless work in India right now. And you're a fantastic example for everybody about the importance of public health and the importance of NGOs working alongside public health and trying to make a difference to ultimately to save lives. And I think you've shared very much our very contemporary tragic example of what happens when we forsake these issues and what happens when we don't take these things seriously. So I hope you stick around so that we can do the group Q&A at the end. And I'm going to turn now to our next speaker, Dawn Sievert. So Dawn is the Senior Science Lead for Antibiotic Resistance in the AR Coordination and Strategy Unit at the Centers for Disease Control. And she's also the lead for the AR Antibiotic Resistance Laboratory Network at CDC. Dawn, welcome.
Thank you, Michael.
So Dawn, Ramanan just shared with us sort of the global challenges related to COVID and antimicrobial resistance. I wonder if you could just share with us briefly what the US experience has been and how the current pandemic has impacted antimicrobial resistance in the United States.
Absolutely. So the pandemic absolutely has impacted our work at CDC on antimicrobial resistance and with our U.S. partners. And one of the things that we're most concerned with is the substantial progress that we made and reported in the November 2019 CDC AR Threats Report. Things like a decrease of 18% fewer deaths from AR infections overall, and also a 28% decrease specifically in hospitals in those deaths. And we're really worried that those decreases now have been reversed due to the impact that the COVID pandemic had on our healthcare system. Also in that report, we showed that there were decreases in some of the very impactful resistant pathogens like methicillin-resistant Staph aureus and carbapenem-resistant Pseudomonas and Acinetobacter, drug-resistant Candida. But then the pandemic hit. And so the stressors that occurred on our facilities and our healthcare systems placed huge demands on our clinicians, on our nurses, on the infection prevention and control staff in healthcare facilities because of the sheer numbers of patients that were coming in with the serious COVID infections. This was a new virus. We didn't understand it. The patients were very sick. We didn't know how it spread. And so this stress on the healthcare system, in addition to supply shortages like personal protective equipment, and we knew that PPE was being misused because people were worried about running out, and then cohorting patients for COVID, and Ramanan sort of touched on this, we're cohorting patients for COVID to make sure that COVID doesn't spread in the facility, but at the same time, we may be bringing patients together that are infected with serious resistant pathogens. So now, instead of containing them like we would during normal times outside of the pandemic, they are now being placed near each other, with each other, with setbacks and things like maybe regular surveillance in the hospital for AR isn't ongoing because they had to cut back. Standard routines for infection prevention and control, reviews of that, reviews of stewardship, all had to be cut back because of the response to COVID. So as you can imagine, with this mix of what's been going on then with the pandemic, we then, as we would have expected, have been seeing these pockets of outbreaks of healthcare-associated infections, sometimes in COVID units, sometimes not, sometimes among COVID patients, sometimes not, but with our serious resistant pathogens that we've been tracking. So unfortunately now what we're seeing and what we've been dealing with CDC, with health departments and the healthcare facilities over this past year of the pandemic, we've been seeing these same pathogens that we saw a decrease now happening in outbreaks like carbapenem-resistant Acinetobacter, Candida auris, methicillin-resistant Staph aureus, and in the same hospitals that we reported so much impact on decrease in deaths, we're now seeing those outbreaks happening in those facilities. So what we need to do now is learn from the lessons that we've seen. How did these stressors affect the facilities? This unexpected huge increase of patients with a new virus. How can we do lessons learned now, review it, and prepare better to have our prevention in place so that the next time a big emergency happens, our healthcare facilities would be more prepared for influx of patients to be able to manage so they can keep up with the AR work that they're doing as well.
So I think, that's a sort of a secondary tragedy that you described, that we had made progress in the United States at reducing the burden of antimicrobial resistant infections. And you just sort of noted that we've probably gone back years because of the COVID pandemic in terms of that prevention. I wonder if you could speak to how did we get to that progress? What did the United States do to see those reduced infections and reduce deaths due to antimicrobial resistance?
Certainly. So since 2016, we've really accelerated our CDC portfolio of AR work, and again, to combat antimicrobial resistance with bacterial and fungal pathogens domestically and globally. But first of all, the work that we do encompasses detection, control, containment, and prevention of AR. So we work to cover all aspects of dealing with the pathogens that we're looking at. We also use a One Health approach to combat AR, and we look at humans, animals, and the environment because we acknowledge that the spread of resistance has no boundaries. And then we also look at prevention from all angles. So we look at infection prevention practices, we look at antibiotic stewardship, and not only use of antibiotics, but use of vaccines and therapeutics and diagnostics when they're needed. So over the past 5 years, CDC has invested in strengthening our domestic capacity through our AR laboratory network. And what we've done with that is we've strengthened the infrastructure of our health departments so that state, large cities, and territories. And in addition to strengthening that overall infrastructure across all the states, we divided the nation into 7 regions, and we added a regional lab in each of those regions. And so the regional labs provide specialized or new AR testing on top of the work that all of the health departments are doing to provide data for action. And again, so that the health departments and facilities can actually address AR locally, because that's what we need is fast identification, quick action on the ground to respond and contain, and then work to prevent further infections. So the AR lab network actually performs tens of thousands of tests, AR tests on specimens and isolates annually. And so what we're doing is we're identifying the pathogens that we're looking for, and these pathogens we follow are the ones that we identify in our CDC AR threats report. We have often specialized phenotypic and genotypic testing where we can identify the resistance profiles. We can determine when an infection is linked. So it may be spreading from different patients, person to person. And so then we know that there may be an outbreak that needs to be dealt with. And then we can also identify patients that are carrying serious resistant AR infections, though not showing symptoms for infection. So we do that through our colonization screening. And why this is important and how it works is basically a scenario of if a patient is in a facility and they either are showing infection or maybe on admission patients are coming into a particular facility, these priority-resistant pathogens like a carbapenem-resistant Enterobacter or Candida auris can be quickly identified through the AR lab network testing, and then that information is immediately reported back. So then treatment with appropriate antibiotics or antifungals can be put in place, contact precautions can be put in place, the patient can be contained, and so this way the individuals are dealt with and that spread does not occur to other patients. So through this AR testing and the immediate sharing of results and all of the collaborative efforts and response that happen across the nation on a daily basis, we've actually been able to prevent numerous additional illnesses and deaths with this work. And in doing that, we've also been able to control the need for more antibiotics and antifungals because we've reduced that additional spread of infection or colonization from those serious pathogens. And now in all of this work, of course, this is sort of what we've done, and now we have a lot still that we want to do. So we look to expand on the successes, again, with innovative testing, laboratory methodologies, and our prevention and control strategies. So to name some of the expansion efforts that we're looking at in the AR Lab network would be increasing those capacities for that colonization screening of Candida auris and the carbapenemase producing organisms. We also look to a broader use of whole genome sequencing, improvements in our standardized sharing of electronic data. We've instituted new testing just recently for capacity of azole-resistant Aspergillus fumigatus and also expanded methods for resistant gonorrhea. So there's a lot of work to be done in that area, but we've come a long way with the work that we've accomplished so far. Even in the midst of the pandemic, all of this work continued over the past year. Sometimes we had to shift things around, but we still managed to keep it all going.
Dawn, thank you. That was fantastic and very helpful. I mean, I think the bottom line that I'm hearing is, from the US perspective, we have really prioritized detection, improving our national capacity for detection, and tying that with expeditious response, especially for very dangerous, deadly emerging forms of antimicrobial resistant pathogens. And then trying to see how we can grow that capacity and working with One Health partners. So I think that is incredibly insightful. And as we move forward, especially for the Q&A, I appreciate hearing more about the US experience and what we have planned. So I'm going to now turn to our last, but certainly not least, final speaker, Ben Park. Ben is the head of international infection control efforts at the Centers for Disease Control and Prevention. He works on improving IPC and in healthcare and improving antimicrobial resistance surveillance in the healthcare setting. Welcome, Ben.
Thanks, Michael. It's really good to be here. I'm really excited to talk about this today.
Well, thank you, Ben. So IPC, that acronym gets thrown out a lot. I wonder if you could just sort of give us what is IPC and why does it ultimately matter?
Yeah, thanks. And this is something I feel really passionately about, having worked on this for a number of years now. And this is something I think that we actually see a lot is there's confusion about what IPC is. So IPC is a specialty. It's a specialty that focuses on making healthcare safe from infectious disease threats. So the way I like to think about this is just like cardiology is a specialty for heart disease, IPC is a specialty for healthcare safety. And IPC is really, so by that logic, IPC is really much more than PPE. It's a complex system that requires smart design, infrastructure to minimize threats. It requires smart policies and programs to influence and improve practice. But probably most importantly, it requires expertise and experience at multiple different levels to implement these policies and safeguards.
And so what has been the experience with the pandemic and IPC? And has the pandemic taught us anything about how we implement IPC globally and how we can better use IPC as a tool to prevent antimicrobial resistant infections in healthcare and across communities?
Yeah, I think the pandemic has shown us a lot. I think healthcare can really, it can make us or it can break us. COVID has shown everyone really that healthcare systems worldwide are not ready for modern threats. Many of these healthcare systems have been suffering, but this is a pattern that we've seen with almost every emerging infectious disease threat, Ebola, MERS, even all the way back to SARS, because the healthcare system is where sick people go. Therefore, healthcare systems have to be prepared. And this really happens through infection prevention control, or IPC. Now as the AMR pandemic slowly unfolds, it's really going to be critical to have a healthcare system that is prepared to take it on. And I'm not quite sure that we're there right now. But one of the things that's challenging is that IPC can't be built overnight. You can't just surge IPC and expect to make significant progress. It's really the result of long-standing commitment to healthcare safety that's really demonstrated by an investment in people, in healthcare workers, giving them the tools and the training they need to stay safe, and in the IPC specialists who can oversee those programs to help keep the whole system safe. I believe we're really at a critical junction in this pandemic. Healthcare workers they're tired and overwhelmed, especially in countries like in India and other countries where the pandemic is just overwhelming. And many of these places, healthcare workers are actually in short supply. Many countries, the healthcare worker to person ratio is very low and lower than it should be. These are precisely the areas where we can't afford to lose them, in these same areas where the pandemic is overwhelming the systems. Because, IPC is, as I mentioned, it's a cornerstone of health system resiliency. If we can't protect our healthcare workers, everyone is going to suffer. Who will take care of the patients? During the Ebola outbreak in West Africa, Sierra Leone lost over 10% of its healthcare workforce in that one outbreak. I deployed to Sierra Leone during the Ebola outbreak, and I remember seeing a wall of just in one hospital, all the names of the healthcare workers that had been lost. And it's just heartbreaking. The toll on healthcare workforce and therefore the healthcare system was just tremendous. And this takes years to recover from. I think right now we're seeing big impacts in global programs like in HIV, TB, malaria, maternal child health, as Steve mentioned. These are multi-billion-dollar investments, and the gains that have happened over years are threatened by these collapses in the healthcare system. So I think it's really important to think about, as we continue to respond to this really ever-evolving pandemic, it's imperative that we continue to keep the focus on keeping our healthcare system safe and functional. But I do believe this is something where we can make real progress. For example, in India, we've been collaborating with the government of India to support national networks, one for surveillance of AMR, one for IPC. And during the pandemic, these networks were really able to rapidly deploy a lot of important information, trainings, guidelines to healthcare workers, medical students, public health officials. And the network is now serving really a crucial role as COVID is surging throughout India. Another example is in Brazil, where we've been working with a network of hospitals there to systematically improve IPC during the pandemic, including 5 of the big hospitals in the hardest hit city of Manaus in the Amazon region. And then I want to bring this also back to Sierra Leone, because we've made some real progress after the Ebola epidemic. This is a country that was devastated by that epidemic, but clearly saw the need for IPC and safe healthcare. And as a result, they invested in their healthcare system through IPC. And today they have a much more resilient system. They have national leadership in IPC. They have newly trained IPC specialists that are overseeing safety, and they have a new national training course in IPC. So really demonstrates that success is possible. And I think the good news is that COVID has demonstrated the role of healthcare and in IPC in preventing the spread of dangerous organisms. And now what we need to do is demonstrate how IPC can play a role in preventing the spread of dangerous bacteria due to AMR.
And I think, so appreciate that. And I think what you said, and touching on sort of a theme that Ramanan brought up as well, it does seem that for every country of the world, we ultimately have a choice in terms of our healthcare system. And that choice, I think to a certain extent, boils down to, do we want a healthcare system where an emerging infectious pathogen, whatever it is, antimicrobial resistant COVID, is going to be stopped and contained, and those patients protected and those healthcare workers protected? Or are we choosing a system, and we're usually choosing it by lack of resources, lack of investment, neglect, where those sick patients are going to come to that healthcare facility, and that healthcare system and that healthcare facility is ultimately going to magnify those problems across our communities, across our countries, and then ultimately, as we saw for Ebola and COVID, around the world. And we fundamentally seem to have that choice. And I think we need to better recognize that crucial role that healthcare plays. So Ben, in closing, I want to, what do you see is the agenda for like the next 5 years for global IPC, healthcare, antimicrobial resistance surveillance, and what's on your agenda?
Well, I think it's really important to demonstrate solutions to a lot of these pressing problems, because unless you show people the solutions, people won't want to invest in them. Over the last 5 years, we've been working with over 15 countries to help with AMR surveillance as well as IPC. And one of the things that we're seeing, honestly, is the impressive amount of multi-drug resistant organisms. Dawn touched on this, and so did Ramanan, about that impressive amount of burden that some countries are reporting. Ideally, these organisms need to be followed by intensive and targeted IPC to prevent that spread. And that's where we're seeing some gaps. We're seeing gaps in using data for action. And I think this is really important, because one thing I really want to stress is that IPC is important to reduce the overall burden of AMR infections, but it's even more important as a crucial tool that targets the most resistant bacteria to prevent their transmission across the healthcare system. And we see this problem of highly resistant bacteria as a looming threat, especially those ones that can be spread easily and can be spread asymptomatically even. We've done some studies that preliminarily show that these multi-drug resistant organisms are circulating and spreading in hospitals and communities right now. And it's, in some regard, this is akin to COVID, where asymptomatic individuals have really fueled its spread around the world. In fact, we know that some of these highly resistant organisms can, and in fact, they already have spread across borders, even spread to our borders. And this is really a clear demonstration of how our own health security depends on things that happen abroad. So to counter this threat, one of the things that we're doing is going to be investing in a new global CDC network called the Global Action in Healthcare Network, or GAIN. This network will be focused on the detection and rapid containment of threats to the healthcare system, like multi-drug resistant organisms, but also healthcare-associated infections like COVID. Through this network, what we're really trying to do is we're trying to break the chains of transmission that's happening right now in healthcare settings that I mentioned. And through this, we hope to show that progress is possible, even in resource-limited settings where the burden, as I mentioned, is really tremendous. And we hope that this network can be a real asset in the fight against AR. And so I'm really excited to let people know about this network. And actually, we're going to be supporting this work through a new funding opportunity that's currently live. So if people on the call are interested in applying, you can go to grants.gov and look up the notice of funding opportunity. And it's called CK21-2104. So I really hope that people on this call will look into it.
Well, thank you, Ben. And I think we can put a link to that in the chat. I think searching for CK20, whatever it ends up being, it doesn't roll off the tongue, but we'll get you some resources so you can find it rather easily, and forgive us on the CDC side for having complicated names for things and the bureaucracy there. But thank you, Ben. And now I'm actually going to ask all of our speakers to come back on. We heard from Ben closing us out there in terms of the presentation about the importance of healthcare IPC, but now we're going to do a sort of group Q&A with everybody. And these questions are open for everybody. I do want to ask all of our audience to send in questions. I think folks can see that we have a lot of people on, over 1,200 folks on worldwide right now. So obviously we're not going to get to every question that you submit, but we really appreciate your questions because it helps us understand what is the most interesting, what is the most engaging, and gives us ideas for future topics that we could consider for an AR exchange. So we're going to close it out with a couple questions here for the group, and these are open for anybody and everybody if you want to answer. But the first question, I'm curious, there's been an enormous amount of political will, an enormous amount of financial resources that have been brought to bear for COVID. And we've spent a lot of time talking about the impact of COVID on antimicrobial resistance, but I'm curious if you were in the position where you were the policymaker and you had both the political will and the dollars that we have for COVID and could bring them to bear for antimicrobial resistance, where would you start and what would you support? Where would your first dollars go, and what would you hope to support to better prepare not only your own country, but other countries of the world in the fight against antimicrobial resistance?
I can take that, Michael. I think that it's obviously not easy because there's a lot of things that one could really focus on. But I think one thing that is underappreciated is really the role of vaccines. And these are not necessarily new vaccines, it's vaccines we already have, which have the capacity both to reduce illness from viral pathogens for the most part, but also reduce antibiotic consumption. But we should also invest in antibiotics for bacterial pathogens, which are more difficult. But if COVID has taught us anything, it is that if the world puts its mind to solving those kinds of problems, then the money flows and it's possible to make happen. I think issues like water and sanitation will take a lot longer because that can't be solved in this kind of, in the lab reflexive mode. And I think IPC is somewhere in between. So vaccination is where I'd place my highest bet. And then on the IPC, infection prevention and control, and then on the water and sanitation in that order. Because the reasons to solve water and sanitation are far beyond just AMR. There are many other reasons to go ahead with it, which includes just diarrheal pathogens and so forth.
Yeah, hi, Michael. I can go next. I think one of the key things to think about is, is how do we prioritize problems and how do we prioritize solutions? I think AMR is certainly a very complex problem, and I think it was Ramnan that brought up the the analogy to climate change. I think AMR is somewhat akin to that, in that policymakers often see AMR as a very complex, highly technical problem. And I think in order to kind of break through that confusion, it's important to prioritize the problems and prioritize solutions, but not just prioritize the solutions, also develop real solutions with real targets that can be tracked, and we can have accountability around achieving those deliverables. I think that's going to be very important to demonstrate that we can make progress. And I think that's going to be important to show what happens when we do make progress.
And then, Michael, this is Dawn. I can add, I agree with all the comments Ramanan and Ben have said. And I think, when we look from the CDC perspective, there are so many activities. And this goes to what Ben said. We need to prioritize. There's so many different angles that we need to attack AR from, and in getting ahead of pathogens. So I think that one thing that is always a focus is, we need to be ready. We need to detect. We need to be ready to respond. But focusing on that prevention piece and all the pieces that go into it. So, looking at infection prevention and control and looking at it across One Health. We can't do this from one sector at a time. We have to do it across all sectors. So looking at, infection prevention in hospitals, biosecurity on farms, how we deal with our companion animals, what's happening in the environment, looking at stewardship across all of that and optimizing antibiotic use and all of those pieces. And again, delving into the environment, moving things forward as far as novel and innovative diagnostics and therapeutics and vaccines to be able to add to the antibiotics that we have. And I think, working on that prevention piece and investing in that, working across at One Health, across all of the sectors, so that our partnerships can come together and we can share information and strengthening all of that and that work and that shared information that we have to actually move this space forward together, I think is the only way we're going to be successful. And of course, it takes funding and support and everyone on the same page.
And Steve.
Yes, Michael, thank you. I've been really moved by the remarks from the other speakers as to the gravity of the situation. But in preparing for today, I read through maybe 50 pages of various articles and studies and things that had come out recently. And I didn't get the same powerful impression from that quick survey that I got from hearing the other speakers talking about the gravity of what is happening. So I guess in terms of prioritizing action, I think there is a bit of a gap here. I would suggest that you invest in assembling the best possible data that reveals what is happening in a dramatic and vivid way, along with an assembly of clear prioritized actions, as we've heard from the speakers here, and expedite that to both Congress and the executive branch as a priority. Because I think that a lot of what you're conveying is not captured, to my knowledge, and I'm speaking as an amateur in this particular field. Maybe I'm wrong, but I'm not sure that the reality of what's happened has been captured in a powerful and vivid way that you can put in front of a Senator Murray, chairman of the Health Committee, who cares deeply about this issue. I just don't think that's happened. I may be wrong, but if it hasn't, I would make that a priority.
Thank you. And I think what I'm hearing from all of you is the need for us to be compelling and honest with the assessments. I think in public health, sometimes we are cautious in our assessments, and we don't want to be in a position where people are accusing us of overinflating anything or doing more to bring unnecessary attention to problems that aren't there. But I think we also need to recognize that it is our ethical responsibility to highlight the dangers and the challenges that we see and outline what we think needs to be done. So thank you all for that. The next question, for all of you is touching on the One Health aspects. And this has come up really across a lot of the speakers today. And, obviously the pandemic has shown the One Health issues. And Ramanan, I think you said it well, that if this hasn't taught us that we need to do better and take a One Health approach, then nothing will. And so I guess the question for all of you then is, given that, the pandemic has shown the One Health issues, antimicrobial resistance, it is, we have to take a One Health approach. We do that from the US perspective. We do that from the WHO perspective and the tripartite. How do we honestly get better at it? I think sometimes this breaks down to where we point a lot of fingers from one industry to another. And how do we get past that to where we all come together and mutually recognize the need for us to do something and do it in a way that's productive and where we all sort of take our responsibility to make a difference?
So Michael, I could start on that, which is that I think the first step is really that we don't approach research and problem solving from the One Health standpoint. If you look at the way in which just research on pathogens in humans and animals happens, these are very disconnected processes. We're in better shape than we were 10 or 15 years ago. And I think one of the great achievements of the CARB process and PACARB has been that it has truly been a One Health process. 10 years ago, there was just squabbling between the two worlds about who is responsible for the problem. And I think we put that firmly in the rearview mirror. And I think that's a huge achievement, in terms of the conversation, at least in the US. I don't know about necessarily everywhere else, but certainly in the US, that's not a valid, reason to hold up things anymore. But I think from the research standpoint, one of the things that CDEP is doing is, first of all, we're being renamed as the One Health Trust because, it's clear that this is really the main way to frame things. But the other part is that we're launching a demographic surveillance site, which is a One Health surveillance site, where we're looking at human companion, animals as in pigs and poultry, as well as bat viruses, all from the same field station, which will be down in southern India. And in looking at health that way, we would be able to get a much better capture on sort of, which of these pathogens you see crossover, what's happening in routine periods of time, what happens in agricultural settings versus, peri-urban versus urban settings. And I think we really need to shift our focus again in terms of how we do surveillance and how we do research into that One Health mode, which I think we're making progress on even in the States. I think some of the studies that CDC has funded, for instance, in Ohio, which are looking at hospital discharge and then looking at impact on farms downstream of the river. These are the right approach, but we need to do a lot more of that sort of thing, and then that will lead to the papers and the understanding and then the consciousness to be able to solve in that One Health approach.
Other perspectives?
So this is Dawn again. And as you know, I've talked a lot about the One Health perspective. That is our focus at CDC as we work with antimicrobial resistance and, try very hard to always work with partners. We recognize that we need that expertise from all of those sectors. And that expertise together is going to be the only way that we start, making those connections and closing those gaps between the spaces and sectors. And as Ramanan was talking about, so focusing on that One Health and bringing the partners together to be able to say, what is happening from the human perspective, what's happening from the animal, the environment perspective, in agriculture, in industry. And so there's one thing that I did want to talk about and have the opportunity before we ran out of time. From our perspective of One Health and expanding our AR work, Ben mentioned this in the GAIN program that he talked about from the healthcare side. And there is an overlap to what we're trying to do overall with antimicrobial resistance and trying to shore up the work that we do globally. So what we're trying to do and what we're in process of doing is taking our foundational structure and the focus of our domestic AR laboratory network and building upon that, working to increase the coordination across the CDC global AR work that's already happening and move that forward, working with partners that are already in the space to establish a global AR lab and response network. So this global AR lab and response network overlaps with the GAIN work that Ben talked about with the AR piece that is in the healthcare facility, but the work that we're looking at is across that One Health impact. So from the this network side, we're looking at healthcare as well as community, animals, food, and the environment, including water and soil, and what those impacts are on each other and on human health. So again, it's part of the funding opportunity that Ben talked about, and our hope is to be able to, work globally in low to middle income countries with partnerships that already exist in this space and add on to the work that our experts are already doing at CDC globally to be able to move laboratory capacity forward and detection forward and response, quick and immediate response and containment, again, so that we can work across the globe to try to contain AR and prevent this spread and try to catch up with it and get ahead of it. And again, catch up with those losses that we endured during the pandemic. Thanks.
And I think I think those are great points that Dawn brought up. And one thing that I want to also emphasize that I completely agree with what Dawn said and also what Ramanan said. I think that the space is really evolving in terms of from a research standpoint, from a research framework. And at least one of the things that I see a lot in the global space, particularly in the international space, is that I think a lot of people understand the concept of One Health. I think a lot of people see that it's important. I think a lot of people really want to approach these problems in a One Health perspective. But I think people don't quite know yet what to do. I think that we're moving towards that direction through these different types of initiatives. But as soon as we can take One Health from a concept to really more of a program where we can highlight what are the key activities, the key deliverables that we're trying to do, and get a great consensus on that, which I think we're moving towards, I think that's going to really help to galvanize this approach because it's clearly important. The concept is understandable. Everyone understands it. But what do you do about it? And what are those key actions that need to happen? And I think we're moving there. But I don't think we're quite there yet, at least not that I've seen it on the international space.
Thank you, Ben. So I think I'm going to go with one final question since we're close to the end here. And this is going to be a bit of the lightning round. And I'm going to put you guys on the spot, but this is going to be 5 years from now. Are we in a better place as a globe to fight antimicrobial resistance than we are today? So really, are we going to be better off or worse off? And what's your best guess as of today? Ben, you're already spotlighted, so I'm gonna put it on you.
I think yes. I'm an optimist. I think we're going to be in a better spot, but we're not. It's not a done deal. We really do have to take advantage of what's happening right now. I think Steve really talked about this really well. Now's the time. We can't wait until the COVID pandemic is over to advocate for these resources and for these solutions. We have to do it now. And I think if we can do it now, then we are in a better place in 5 years. And that really will depend on how much progress we make in these next 12 months in trying to advocate for these problems.
Steve, what do you think?
Well, I am innately an optimist, and so I'm going to, land there by saying that I think the world can and should be much better in this respect. I do think that it's really important to think ahead today about that 5 years and 5 year target and lay out scenarios that paint what the threat is. People are going to respond when they understand better what the current and future threat may look like, and lay out scenarios that are optimistic and not so optimistic. I mean, I know you already do some of that and do a lot of that, but my takeaway from listening to these amazing experts talk is that there's a lot of ferment right now. There's an enormous amount of ferment, and there's an enormous amount of angst and uncertainty in this field because for all the reasons that were laid out. And so capturing that ferment, capturing the threat, and laying out scenarios that could get us to a much better place, I think will get the attention of the folks today whose attention is very, very overwhelmed. Policymakers are very overwhelmed by the immediate crises that we face. Although, as I've said, I think we're pivoting away from that, even while still a bit nervous here in the United States about what lies ahead. Thank you.
Thanks, Steve. Ramadan?
So I think a lot really depends on the United States, and I'm putting the focus back on us because I think this is really something which the US has ceded ground on global health the last 4 years, and it needs to get that leadership position back. And if this is a position of leadership both to show it can be solved in the US, which it has been, I mean, since 2014, amazing things have happened, as we all know. We've gone from under $2 million in funding to over $1 billion in funding, and significant progress in many fronts. But I think if the United States were to use that leadership and also lead from the front, particularly at WHO, but not just WHO, everywhere else, then this could really get somewhere. But I think it really depends on US leadership here. And if that were to happen, I don't see any reason why it couldn't happen.
Thank you. And Dawn, quickly, the last perspective.
I'm going to be a worried optimist that I worry what would happen if we don't, but I truly believe that there's enough heart and energy and expertise in it that if we come together, we will actually make progress. And I think we're ready to go.
Well, there you go. I want to thank you all again. Really appreciate all the perspectives we shared today. And I hope everyone really appreciates the coming together of these disparate ideas. And I want to thank all of our speakers for their insights as well as their leadership in their respective fields. I also want to thank the team at CDC ARX. You're a great group of people to work with, and you are leaders in your field, and want you always to appreciate all that you do. And lastly, I really want to appreciate and thank the audience for joining us for our first webinar. This is going to be the first in a series. And we are going to be sending out news and messages for upcoming webinars and upcoming topics, so be on the lookout for those. We're also going to have a survey that we send out to check on your feedback on this so that we can improve. And I just want to close with how I began. So good morning, good afternoon, and good evening from wherever you're joining. And we really appreciated you joining us for this conversation of the AR Exchange, and look forward to many more in the future. Have a great day. Bye-bye.